I'd like to present our next speaker, Dr. Syena Moltaji is a breast and microsurgeon at the University Health Network with a focus and interest in oncologic microsurgery and lymphedema surgery. Our presentation is titled Lymphedema and Lymphatic. I'm having a list. Lymphatic Reconstruction. Please welcome Dr. Moltaji.
Okay, good evening, everyone. I'm Syena Moltaji. I'm a plastic and reconstructive surgeon at UHN, and I started here this fall. I offer both implant and tissue-based breast reconstruction, as well as reconstruction of the lymphatic system to prevent and treat lymphedema related to breast cancer. Every year, thousands of Canadians finish their breast cancer treatment feeling relieved, only to face a new challenge, lymphedema, a chronic swelling that can appear months or years later. And lymphedema affects up to 1 in 5 women after breast cancer surgery. Today, I'll explain how the lymphatic system works, why lymphedema happens, who's at risk, and how we can both prevent and treat it, including some of the cutting-edge options I plan to offer at UHN in the near future. The lymphatic system is like the body's plumbing for fluid balance and immune defense. It's a web of tiny vessels that collect excess fluid and proteins from tissues, filtering them through lymph nodes, especially in the underarm, groin, and neck, before returning them to the bloodstream. When those pathways are interrupted, the fluid has nowhere to go. Imagine removing a few drains from your kitchen sink. Eventually, the water backs up. That's what happens after node removal or radiation that damages the lymphatics. The drainage system is damaged and fluid accumulates. Lymphedema is persistent swelling caused by blocked lymph flow. In breast cancer survivors, it usually affects the arm, hand, or chest wall on the treated side. Early signs include a feeling of heaviness, tightness, or clothing that fits differently. Over time, skin can thicken, mobility can decrease, and infection risk rises. It's not just a cosmetic issue. It can affect strength, comfort, and quality of life. The earlier lymphedema is detected, the easier it is to control. Lymphedema risk rises in our breast cancer patients when the lymphatic system is damaged by surgery or radiation. Your breast general surgeon may recommend removing a single or multiple lymph nodes because breast cancer can spread through these channels, and we may need to test, remove, or radiate the nodes as part of your treatment. In surgery, lymph nodes are removed and channels can be cut, causing persistent leak, while radiating the vessels can cause scarring, which leads them to not pump or move fluid as effectively. This chart from Harvard shows how the risk increases based on the type of treatment that you have. For a sentinel lymph node alone, the risk is 5%, while adding radiation to this doubles the risk to 10%. The risk is significantly higher at 25% in patients who have a lymph node dissection, meaning all the lymph nodes are removed from the axilla. And the risk is highest when both the dissection and radiation occur at 30%. Years ago, patients were told to protect that arm and don't move it. We now know the opposite is true. Gradual movement helps with lymph flow. Prevention includes early stretching, physiotherapy, good skincare to avoid infections, and maintaining a healthy weight. Surgically, we can now also protect the lymphatic system. In patients undergoing an axillary lymph node dissection, a microsurgeon can perform immediate lymphatic reconstruction. Using a microscope, we identify any cut lymphatics and connect these lymph channels to nearby veins as the nodes are removed, giving lymph a new pathway immediately. Early data from Memorial Sloan Kettering shows that immediate reconstruction can decrease the risk of developing lymphedema from 32% to 9.5% in this population at 2 years. If swelling develops, we start with non-surgical care. compression sleeves, manual lymphatic drainage massage, and guided exercise. This full spectrum of non-operative care is often termed complete decongestive therapy, or CDT, and is carried out by a certified lymphedema therapist. To see what's really going on and determine if someone's a candidate for surgical treatment, I perform an in-office procedure where we inject fluorescent dye and look at how the lymphatic channels light up along the arm. The channels should be lines leading up to the axilla, which you can see in image A. In lymphedema, there can be areas where the lines turn into little leaks, or areas of dermal backflow, which you can see in image B. In severe disease, like that seen in images C, D, and E, there are no channels at all, and the entire limb has this backflow pattern. If a leak is present, I can see the line stop where the dye is pooling and know that you may benefit from a bypass procedure distal to that leak. In lymphovenous anastomosis, also known as lymphovenous bypass, we connect blocked lymphatics directly into the tiny veins. It's like creating new drain pipes. If we look and see no functioning channels, just leaking in the whole arm, this is advanced disease. It requires a larger operation called a vascularized lymph node transfer. In this procedure, we take healthy lymph nodes from somewhere else, usually inside your abdomen, and transfer them to the affected area. These nodes reestablish drainage, act like a sponge to soak up the lymphatic fluid, and a pump that stimulates lymphatic flow back up the arm. In patients who have developed severe fat and skin thickening, I may recommend liposuction debulking before looking at one of these other procedures. It's important to know that while these operations improve the feeling of heaviness, they may only modestly improve the increased size of the limb, and therefore they're functional operations more so than aesthetic operations. To the right, you can see a clinical image of what a lymphovenous bypass looks like in the operating room. The green line in the top picture is a lymphatic vessel, which has been lit up with fluorescence so that we can see it. And the pink one below is a vein. In the second picture, you can see how the two have been connected, and that fluorescent lymphatic fluid is now draining into the vein. Each of those squares in the background is 1 millimeter by 1 millimeter, which gives you an idea of how small these vessels are. Because of the extremely small size and the need for the fluorescence to see, this operation requires a very specific Japanese microscope made for lymphedema. We know that access to timely lymphedema care has been a major issue for our patients. It's in the news, and it's in our clinics every week when we meet patients who ask about or would benefit from this care. UHN recognizes this need, and we hope to bridge the gap in 2026. We are launching a dedicated clinic for patient assessment and working with our foundation to identify donors who can help us acquire the equipment necessary to provide our patients the highest quality lymphedema care the world currently has to offer right here at home. If you are a UHN patient and are experiencing lymphedema, you can be referred to the Princess Margaret Cancer Rehabilitation and Survivorship Lymphedema Clinic and request a consultation for surgical treatment. With the right care, lymphedema patients can live a full and active life. I wouldn't be able to offer this care without my mentor in lymphatic surgery, Dr. Yuma Fuse from Tokyo. Thank you for listening, and I'd welcome any questions.